So my name is Yahya Ifawi. I'm a consultant neonatologist. This is for the YouTube, not for you. So today we're gonna continue what we started yesterday about loops. And we were talking about volume pressure loop. And as you know, the loops is comparing two respiratory parameters to give you the dynamic of one cycle. So we were talking about the relation between the pressure and the volume, and we've said that when we say pressure zero, we mean the atmospheric pressure, and when we say volume zero, we mean the functional residual capacity. So we've said that start from zero and it moves slowly, you increasing pressure, and all of a sudden you get a point where you get much of change of volume with the pressure, and then that change decrease, and then the elastance start. So here you have inspiration, and here you have the expiration. So here you have the magic point or the opening point or lower inflection point, and you have the upper inflection point, and then you have the closing point. And we've said that we have area A, B, C, and D, and we like the ventilation to be here. Correct? So all that's good. So we said this is a dangerous area, and we said this is dangerous area, de-recruited area, hyperventilated area. So what we love to see the ventilation. And then we have something called slope, and it's the correlation between the pressure and the volume. And so when we go like this, we're achieving less volume, and that's mean, what does that mean? Poor compliance. When you move like this, we get achieving more volume, and it's a better compliance. Okay. Now today we'll take it further, more difficult, but more. So we will talk about what's the benefit of this. The first benefit is we can know the type of breath. If we know the type of breath, we know the mode of ventilation. So in ventilator, we have three breaths. We have the spontaneous, we have the mandatory, and we have the assisted. Spontaneous done by the patient, mandatory delivered by the machine, and assisted started by the patient and completed by the machine. And there is a correlation, there is a connection between the baby or the patient and the ventilator called trigger. So you increase the trigger, you make it more difficult for the patient, more machine dependent. You decrease the trigger, you make it toward the patient. So it's a correlation between how much you want and what is the phase of your ventilation. Are you starting, are you continuing, or you're weaning? And then you can determine. So people sometimes use it for weaning. Some other people use VG to wean, but you can use this. So, this is a very important area. Okay, and by loop definition, this is called hysteresis. So you have two types of hysteresis: normal hysteresis, abnormal hysteresis. How you know? You compare it with the PEEP. So if you start PEEP here, let's say 6 centimeter water, and you start from here, okay? Okay? And there is another one, if you start like this. So which one is normal, which one is abnormal? So you can see this is normal, probably this is more hysteresis, more abnormal. Okay? And hysteresis is the worst part of the inspiration. Also, it's part of the compliance. And then the chest should bring it back to zero, and that's called elastance. And elastance is the reciprocity of compliance. So elastance equal 1 over compliance. So the machine or the baby itself want to inflate, it depends on the type of breath, and the recoil. Okay? And therefore, when you do that, you need energy. When you do this, you don't need energy because it's elasticity. So the best ventilation where you have the compliance 30% and the elastance 70%. Because that means you need less oxygen and you need less calories. And therefore, sometimes sometimes you see in practice, when I see baby is not growing, I put him back on CPAP. And the reason is because I want the elastance to be dominant. I want him to rest. I don't want him to use his compliance. So when he does not, then I would save about 10 to probably 20 kilocal per kg per day, and that will help you. So remember, how you do that? So if you draw it again, so you start here like this, okay, and then you put this on. Normally this one should be 30%, and this one is 70%. That is the best oxygen consumption and calories consumption. And the other point is up to 50-50 is good. So 50-50 is good. More than that is better for the calories, especially if you are not gaining weight. If it's reverse, then you have a problem.
What do you mean by 30 or 70? What does it,
We'll talk
how to calculate it?
From the slope, from the beginning to the end. The slope, the compliance slope. So let me finish. So if you draw like this, and you draw your so you start with your hysteresis, you go up, and so from the beginning to the end. So it's very good if you are 50-50. If you are more than 50 to 50, it's way better. So, but the less compliant, the more you depend on the recoil, the better, because you're not using energy. That would be the best. But 50-50 is better. When this increase, because you are more depending on your compliance, on your distensibility. When this increase, you're more depending on your restrictive function, your elastance, your recoil. So usually it should be 50-50. So if this increase, mean your compliance is not good. If this increase, your compliance is good because you are depending on your restrictive function.
So you're talking about the distance between the curve and the line?
And the slope.
Okay.
And the slope. The slope between volume and pressure. There is a slope.
Distance here and distance
Correct.
here.
Yes, from the line till the scope. Okay? Any question? And now we will talk about the type of breath. We have three, how you recognize it from the, for example, if you have a baby that is on ventilation and your pain score is high, and you want to know from the ventilator, is that sedation is good or not? You look at the graphics. So if you have it like this, what's this type of breath? This is assisted. If you have it like this is spontaneous. Okay? If you have a typical, this is mandatory. So you have three types. You have a triggered one, the baby create negative volume and negative pressure, and then to trigger. And this space depends on how much trigger you give to the patient. So if you have 0.2, it's very small. But if you make it like what I did right now for the baby I was extubating, is 1.2, then it looks like bigger. When it's very typical, it's usually mandatory. When it's more toward the volume and less pressure, then it's more like spontaneous. And it depends, so if I have mandatory and spontaneous, I know this is either IMV or SIMV. It will never be PSV or SIPPV or assisted control. If I see this and this, then I know it's SIPPV or, okay? And also it helped me decide about the sedation. So these are the type of breaths. And then let's think about also C20 over C. Because I know there is some difficulty to understand it. I made it a mess. like a serialist. So if you draw the pressure, the volume, the pressure, if you draw the volume pressure groups and you do like this, you start typical one, okay, and you have some kind of hyperextension because you have peaking, okay, and if you draw your slope and you draw your peaking, you'll see this angle is big, okay, and it's almost way bigger than the slope, okay, and that's mean this is called C20 and this is called C, okay, so if you divide C20 over C, okay, and it is less than point, I would like it less than 0.6 mil, mil per second. So if like this, okay, it is, it means that, imagine like it's a balloon, okay, and you reach to the end of the inflation. So still at the end, you have a room to inflate. That means still good. That means you are not hyperinflated. So the less, that means you don't have room to inflate. So what I like it is to be 1. So C20 over C, it looks bigger. If it's 1 and more, then think in this way. At the end of inflation of a balloon, you still have room to inflate. While if it's less than 0.6, at the end of it, you don't have room to inflate, which means you have peaking. How you notice it? Just draw a slope. After hysteresis of the rising, after the closing, you draw a line, and then draw another line about, and then you can see the angle. The best one, it would be like this. So you have it like this, and like this. So if you draw a line like this, and you draw like this, so they are parallel to each other, and that's why they equal 1. Until they start to do like this. So in the reverse, okay? And they have become more than 1. That would be great, because at more than 1, you still have room, double your compliance, right? Because you say at the end of 20% of the slope, I'm still having double the amount of compliance that I already received from the whole cycle. Okay, so give you a sign that compliances, even if you cannot look at the graph, then from the compliance or from C20, it will help you. You are over distending or not. So we've talked about hysteresis. We've talked about compliance.
Normally it should be
Less than 0.6. Now the number depends.
More than 0.6.
Less than 0.6 is bad. More than 1 is very good. In between, I'd like to use the number 0.8 usually. Okay? There is no evidence. It's all like experience and anecdotal stories of using it because it's a new. It's not. But the more, the better. Okay? But if there is exact number, not only exact number. Is this number change with gestation? Is this number change with postnatal age? You don't know, right? But I would love it to be more than 1 because imagine like that. You're still last 20% of the compliance and still you have room to do the same of the compliance. So you see how you are dispensable. What else we've talked about? So we've talked about hysteresis. We've talked about, now we talk about leak. So this is volume, this is pressure. Okay. Now we'll talk about internal peak from the graph. Now remember, this is your peak. So this is the pressure, this is your peak. And let's say you set it at 6 centimeter water. And this is your 6 centimeter. However, you're starting from here. So this is your set peak. And this is your peak that you see. This distance is your internal peak. How you manage if you have internal peak?
Is that there is auto peak.
There is auto peak or internal peak. How you manage to avoid it? Is it good or bad?
Bad.
It's bad. It's very bad actually. So how you manage it?
Sedation.
You can give sedation. You can give sedation.
Increase the
Treat
You
the
can
cause.
increase the PEEP.
In a dead space.
You can increase the PEEP. So instead of 6, you make it 6.5. It depends on the measure, of course. If it's 7, then you need to increase it by 1. That's one solution. Another one?
Increase the expiratory.
You can increase the expiratory time. So you give more time for the patient to go back to that. So you increase this. So they can go back. So you increase expiratory time or decrease in expiratory time. So you decrease this and then patients start from here and then they go back. Or increase your P. Very important. Now if you have this hyperextension, how you manage it?
Reducing the PIP.
You decrease the PIP. That's one solution. 1, 2.
Increase the PIP.
Increase the PIP. That's 2. 3. Any other solution?
Maybe sedation.
Sedation. What else? If you're managing, you can give Survant always. That's a question or an answer for any question. But also you can do what? You can, if you're using tidal volume, you can increase your tidal volume. You can decrease your tidal volume.
Decrease that.
Decrease the tidal volume.
Decrease tidal volume, it will be at the end, like, reduce the delta P.
Correct. What else we didn't speak about? Do you remind me anything? Early. Well, of course, early you can see it from different way. All the ventilators will give you a percentage, but you can see it from the graph. So this is volume, and this is pressure. So instead of starting in this way, you do it like this way. You'll see it like this way. Okay? So, in addition to the leak, what do you see here? What is very important here? This is volume,
It's
remember?
not achieving the volume we need.
This is volume, this is the pressure. We said this is 0 and this is 0. And when we said this is 0, mean this is FRC, right? And when we said this 0 mean atmospheric pressure, right? So what this tells you then?
Non-volume.
What?
We have
Yes.
air trapping. We have air trapping. This
You
is
have-
not coming 0.
It's not coming 0. So we are not going back to the functional residual capacity, which means we have tidal volume is
Remaining.
we have we're air trapping. So in addition to the leak, we have air trapping. But we can do like this, if we can see like this. So still we have leak, but we don't have air trapping. What else we talked about? Rest, hysteresis. Oh, work of breathing. How will you look at the work of breathing and decide to give sedation or not? صارت يعني So you have here, and you have the slope. Okay? So more you depend on this, you're more depending on the compliance. Thank you, Hafiz. Thank you very much. It's okay, it's massive, so. So you do like this. If you do like this,
Need to dry.
Not dry. It's okay.
let's do it here. Right. So if you do it like this, and this is your slope, and you're depending on this. Okay? So this is better compliance. This is more restrictive function, or more elastance. So you can see more compliance, more restrictive function. Okay? The more you depend on this, the better for you. The less sedation you need. The more you depend on this, the best you save 100. So the best would be 70% here, 30% here. If 50-50 is great. The more you depend on the compliance, the more you need, the baby is functioning, the more sedation you need.
Yes.
Or non-compliances or sedations or the parenteral.
So you have the compliance because you're putting pressure on the patient, right? So the lung will expand. But then you stop, not all of the ventilator will suck. Most of it's compliance back. So your elastance, bring it back. Your recoil, and that's what we call it restrictive function. So what you want to depend more on the restrictive function because you are not using your energy. So the more you depend on the compliance, the more energy you need. The best you need it to be 50-50. The best one, or the permissible or the acceptable 50-50, but the best it would be 70 on the restrictive, on the elastance, on the return function, and 30% on the compliance or the inspiratory part, not the inspiratory.
If things work complete, if the baby is not happy, he's just...
Correct. So the more you like this, that means the more baby can contributing. If you don't like it, you bring it back. If you're extubating, then that's good. But if you want to ventilate the baby, then that's not good. So it depends on which phase of ventilation you are. But remember, this is more with the machine, and this is more with the ventilator. More with the patient, sorry. So machine, baby. Machine, baby.
What about resistance equation?
Resistance we'll speak about in a separate lecture because it's lots of talk. Because you have to understand the flow with the volume, and there are lots of things to speak. But if you understand now the pressure volume loop and compliance and resistance, hysteresis, opening pressure, closing pressure, over distension, de-recruitment, spontaneous, assisted, mandatory, work-of breathing, and I gave you a PDF copy about work-of breathing and how you can solve or correct the work-of breathing. And it's again depends on which situation. Like with this baby now we're extubating, we need the work-of breathing to be high. Right? We need the baby to contribute. So what we need this to be bigger and bigger. We need this to be smaller because we're extubating, we're training the patient. Okay? Because one of the way to train the patient to trigger is make this bigger. How you do that? There are many. Decrease sedation, increase the trigger, make the mode more baby dependent, like PSV or IMV. Or IMV we don't use, but you can use SIMV, or you can use PSV, or you can use decrease the rate and decrease the trigger. So you need to see more spontaneous if you are on SIMV, and you need to see more assisted if you are on SIPPV or PSV. So you need to increase this. Okay? But however, when you do that, you don't need to do it for a longer time because you start to lose weight. Because you need more oxygen, and even sometimes when you go, because some people, when they put on PSV, they start to see the baby need more oxygen. And they think that they are failing. That's incorrect, because now you're asking the patient to do more oxygen consumption, and that's why you're increasing your oxygen need. So that means when you put a PSV for more than 2 hours, you're increasing this. So you're asking the patient to drive the ventilator. If you are with a premature baby, then you're asking like a drunk, okay, to drive a car. Okay? So if that can drive for 1 hour or 2 hours, it's great. You don't need to continue. But if you continue, nothing wrong. But remember, you exhaust the baby, you increase oxygen requirement, you're losing the weight. Okay? So if you're carrying 1 kilo, you don't want to do that. But if you're planning to extubate, then that's great. But remember also, next day when you lose weight, you know why. You don't need to increase fluid, you don't need, right? Because you know that if you continue, then you need to give more energy. However, when you give more energy, it's more load on the bowels, on the PDA. So you have to know what you're doing when you ventilate. Questions?
Thank you.
No? Thank you very much.